And I think then we can go over to our panel discussion. And I hope that everybody comes back onto the panel, and then we can start our discussion. There is so much which pops up as questions. So maybe that one question which I just saw here, maybe we start with this, because that's also related to some fundamental things. We were talking about people with cognitive impairments, with dementia. How are we able to get this consent from patients, a willingness, written consent, where it is required? Does anybody have an answer to this, how we want to deal with this consent or consenting?
So this is Harpreet. So, I mean, I can say that in the FDA guidance around clinical trial conduct, there are 2 to 3 questions which specifically address obtaining remote or virtual consent with a legally authorized representative. But remember that the FDA guidances are not legally binding, and IRBs and healthcare systems, and particularly institutions, are not required to adopt this guidance. And I think something that Beverly said was really important, and I think this is another group that we really need to engage, is IRBs, that, you know, we can give guidance around flexibility, but, you know, Dave is saying that it's some states and institutions and healthcare systems that are not permitting remote consent. And I think we have to get into why. And is it because there's a perception that the FDA would prohibit this? Because we certainly would not. We're giving guidance on how to get remote consent with a legally authorized representative. So I think we need to engage some of the folks that where there is resistance, and perhaps why. And so that's you know, that's my contribution regarding that topic.
Mm-hmm. Any other thoughts?
I would just say, I think it, you know, as Harpreet has alluded to, there's kind of a lot of institutional variation. So I obviously can't speak to what others are doing. We're struggling with this ourselves here, and we have a very strong, for example, geriatric oncology program where we do a lot of behavioral interventions where we can do remote virtual consent. I don't know if there's a sense with interventional trials or therapeutics, whether there's sort of a different standard for remote consent. I think those are issues that we're trying to deal with here as well with our IRB.
Yeah, I would just add to that I think some of what's going on now is a lack of familiarity with these things. So if you have an institution that has always gotten documented in-person, written, informed consent, this just represents a change for them. And I think people are often resistant to change. Whenever I give talks about change, I always show a British newspaper article from the 1800s that says, there's this new device in medicine, it'll never take hold. Turns out that was the stethoscope. So as physicians, we're very resistant to change sometimes. And I think sometimes what helps with change is evidence. And I wanted to reinforce what Erica said about implementation research. Showing people that this stuff works already de-risks it for people who have less willingness to do it. And I think that's an important part of this.
Yeah, I'd like to weigh in on this. We did a trial in atrial fibrillation detection, and we did it all remotely, a digital trial. It was actually the first digital trial published in JAMA. And we had 6,000 people consented to participate remotely. The average age was over 70 years. So the whole idea of doing remote trials and getting consent and getting active participation, these people were all sent a patch that they wore for 10 to 14 days to detect whether they had asymptomatic atrial fibrillation. We're well past that. There's no reason you can't do informed consent among people 70 and age and plus. It works well. We've done it in thousands of people.
Thank you. So, I mean, that is a very, very interesting remark, because at the end of the day, we talk about this consent in any clinical trial. Now
I was referring in good part to the language in consent forms and to make it more user-friendly. And that's when we found a real impasse with the IRB. We were able to make a couple of changes, but we were not able to really modify it in any significant way. And we found that difficult for patients during the recruitment process. I mean, patients did get recruited. The study went forward. The study was accomplished. It was successful, but it still seemed to me like it was a barrier that didn't need to be there, that there should be more flexibility in the content and in the language.
So you see language as a barrier to consent because you are afraid of the language, you don't understand the language, or it doesn't give you the information you want.
Right. It was just complex. It was complex language. It was not, and it was medical language. It was not lay language. It wasn't something that was easy for a layperson to understand.
Yeah. Interesting.
And it felt, and probably was, because it's more, again, to protect the institution than it is to consider the benefit to the patient.
I think that's not the focus of this panel, but the issue of length of consent forms, how they become indemnification documents instead of informative to participants, that's a completely different issue. And that applies to people of any age, I think.
No, that's true. That's true.
Yeah, but John, you said that the difficulty is really the change, to do something differently, right?
Right.
And
well, and this is an example, because for me, it gets back to the inequalities and disparities that are happening, because we're not doing the outreach that we need to bring people in, to give everyone access. We're talking about access. You want to open the way for more access. And when you have something that patients have to sign on to, but they can't understand, you're not opening the road to access, you're setting up barriers. So it is applicable.
But how is it done in the telemedicine trials? When you do clinical trials and you use innovative technologies, you said that there is not really a difficulty on enrolling patients, that they work with you. That's what I understood, John, from you, from the way how you do the clinical trials differently. So will this stay afterwards, after the COVID? Do we learn by simply doing something different? Will this trigger change?
I think part of that's on us. I think Beverly brought up this issue of, she used the word complicit, but I think we need to insist that a lot of these changes continue. I mean, many of these things should have happened already, and COVID was kind of just the thing that goosed us along to move a little faster towards implementing them. I mean, my wife's a practicing pediatrician, and for all the reasons that others brought up here, she had not implemented telemedicine in her practice. She is now, and she's planning on continuing it after this pandemic subsides. So hopefully many of those things will continue, and they should continue. And as Beverly pointed out, we should insist that they continue, because they've got clear benefits for research participants and patients.
Yeah, I totally agree. And I think, from the FDA perspective, this workshop is about drug development and thinking about, all therapies, but novel therapies and bringing new drugs to market. And so how can we how can we implement on a broad scale this decentralized approach and for investigational agents before they are approved. And so what we're doing now is very much actively engaging with industry, because we do need to learn from them in a very rigorous way what they did on a global level and how this was documented and what the outcomes were. Meaning, what was the impact on the integrity of the data that they obtained? Was there any impact? How could it be mitigated with use of more televisits and shipping medications? And then take from that lessons learned and show that this can be done and should be done in the absence of a pandemic. We totally agree. And, my daughter just turned 2 and she's been having virtual visits with her pediatrician. So whereas before I agree, you wouldn't think that this could be done or should be done. And absolutely. I mean, just, personally, you think, oh, they have to be examined, but they're virtually, meeting and then going in the next day for just height, weight, and their vaccine. So I think there's ways we have to be creative. And in being creative in the setting of a pandemic, I think opens up more accessibility to patients who wouldn't otherwise be involved, have as much contact with good health care. So totally agree that this should persist past COVID.
Specifically what I saw, and that is also a question, this sharp drop when COVID came in the patients who are going to hospitals. There was definitely some kind, of barrier, and they discontinued the treatment. And, for these patients, I think it's not just by COVID, but there is a lot of older patients who cannot go to the hospital or to the doctor, or it is a huge burden. Will we have new tools to offer after COVID based on what we learn right now in applying such telehealth technologies?
If I could sort of opine on that, it's one of the things I think that's been interesting to me, and I'd love somebody to do a study on this one day, is how often the outcome measures of these studies, especially with COVID, have been related to what clinicians do, like decisions to hospitalize. And Sven, you just brought up whether somebody gets hospitalized in this pandemic is completely altered from what we were used to. So one could ask the question, isn't it more important how the person feels than where they're sitting, whether they're in the hospital or not? And especially if you have decreased access to hospitals, if you're far away, if the hospital is full, or frankly, if you're just scared to go to the hospital, because some people felt they were more likely to get this disease if they went into a clinic or a hospital. So I think that sort of brings up the issue. A friend of mine once said, we love clinician-reported outcomes because as clinicians, we think we can control them. And I think a lot of that then relates to us letting go. Let the patients tell us what they're actually experiencing. And you just raised a very important issue about, relying on outcomes like hospitalization may not at all reflect what's going on to people, especially in this pandemic.
Yeah, and you were asking about tools that may be available beyond the pandemic. And I think, Beverly, you made a really good point that this crisis has maybe forced us to think about realigning with, some of our priorities. And I hear frustration from Dr. Topol about, we've had this for a long time, and why, what's the inertia with using it? We know how we can do this. Why aren't we realigning with these innovative and creative ways to deliver care? But now that we've sort of, we should have seen the rifts a long time ago, and a lot of us have. But I think, as Beverly points out, they're now very glaringly obvious, and not just in medicine. Medicine isn't separate from society or culture. So it's kind of a big realignment that needs to happen, and I hope it does. Unfortunate that it took a crisis to get us to maybe face that.
But it's only going to happen if we, as individuals, take it on as a commitment to make it happen. We can't, just hoping that it does isn't going to make it so. It's too easy to continue because there is validity in what we've done. We've made changes. We've done well, and this workshop shows how we're communicating with each other and how we're able to talk about the strengths and the weaknesses and what else needs to be done. But we're not going to make that sea change unless we keep really focused on getting that done. And it's going to be in a lot of small ways. It's going to be in the way we deal with each other. It's going to be the way in which we integrate all different kinds of populations to come together to understand each other. And that happens, it's in the clinic, it's between the patient and the providers. Patient attitudes with providers sometimes are very difficult. They don't trust their providers for reasons that are unreasonable, that may be because of race, because of language, whatever. And providers have to examine themselves too. How do you respond to every patient that comes in to your office? That we're very selective in what we do. And I think we just have to be totally sensitive to it all of the time.
Do you think that we will have some more remote technology for diagnosis available soon? Because we have all this geriatric assessment and a lot of this functional behaviors and of people you can measure, with very smart sensors. Do you think that this will give also a push that we take a look into this technology from a user perspective? And I mean, that maybe what we have seen in this study, I think, Erika, you put on, which was just in JAMA Internal Medicines published, that, a lot of patients have no readiness for this technology. The younger will be more familiar, but what can we do to make this technology easier to use? So the human factor design, that it's easy, that it's understandable. Do you think that this COVID will also give a push towards a more user-friendly, user-oriented technology?
It will do that, but I think also, and others can respond, but I think we also have to do parallel strategies, because we'll never reach everyone 100% through technology. And it's easy to make that kind of the goal and not have ways for people who don't access technology to be included. So we have to think of parallel lines, even though one group may be very small in comparison to the other group, but we have to pay attention to that group as well.
Yeah, I think we often frame technology in terms of bells and whistles and new stuff. We've actually been mailing out packages to study participants with self-blood drawing devices. I think the mail's been around for a pretty long time, right? And Alexander Graham Bell invented this crazy thing called a telephone. And in patients who don't have internet access, we've been calling them on the phone and asking them the questions over the phone. And most people have access to a telephone, at least, even if they don't have access to the internet or don't know how to use it. So I think some of this is utilizing technologies that have been around for literally 100 years and putting them to good use as well for people who either don't have the ability to use or don't have some of these more modern technologies.
Yeah, that's the parallel strategy I'm talking about.
Yeah, there might not be one single answer to this, but I think we need to have more tools. And I was also very much surprised about what you said, what some of the speakers said about the geographical barriers, which then asked myself a question: do we ever not only consider in our clinical trial programs age groups, but do we also consider geographical groups, so rural people and people living in the city. Will this help us to broaden and reach out maybe to patient population we haven't reached out?
Yeah, this has been a big focus even pre-pandemic at U of R, and I know a lot of other institutions. We serve a big rural population. They don't have broadband, so that's become very relevant in the pandemic. But we are looking at a lot of models that not only, a lot of the things that Harpreet's talking about, but also, we're training research coordinators to be sort of on-site and coordinate. We've run here a lot of large community-based trials through the NCORE, the NIH-funded community oncology research program. So again, these are something that we've had the capability of doing, of bringing the care to people where they are for a long time, whether it's with high-tech bells and whistles or just having a research coordinator go into a clinic somewhere out in the middle of nowhere and do a geriatric assessment, which is not rocket science. It's asking people questions and watching how they walk and testing their cognition. So these are things that can be delivered anywhere in the US. I don't think there's anywhere that's technically inaccessible. It's just a question of where we're putting our attention, to Beverly's point, and where we're putting our money. And I think so needs to be the groundswell, people like Beverly keeping us accountable for, the focus on the ground, but also the policy solutions that actually kind of overcome that inertia, that we've seen with telemedicine since 1997 and before.
I think there's an aspect of geography that we don't often think about. Deborah Collier, who was on a previous panel, and I have been working on a project where we've been looking at involving patients in the design of clinical studies. And by that, we mean asking the patients about aspects of a clinical trial that could be improved. One of the things we found that's really challenging for people, parking. So even if they live very close to the clinic, they get to our institution and they can't find a place to park. So things like that can be overcome by these televisits or by getting blood draws done at home through these self-administered devices that we're mailing to people. And the other thing is, I think that helps us as clinicians or clinical trialists to think more about what we're actually measuring in these studies. I've seen so many studies that measure all sorts of blood parameters, and they never even get analyzed at the end of the study. And we need to simplify these things to what patients actually care about. And therefore, we don't have to bring them back for so many visits if we just focus on the most important things.
Yeah. So there was just coming in a very, very interesting question. Now that's really a challenge. The question is, will video medicine for new relationship inhibit to develop trust? So do we get this patient-doctor relationship? Will this change? Will this get better or worse? Because when I'm looking to how people use smartphones and media, social media, I would say maybe we get more information about a patient than if a patient is sitting in front of a doctor with a white coat issue. Will this change then the attitude or the way we get information? Maybe what do you expect? Will we get maybe an addition or less as information in this, if this relationship will change?
This is a really interesting question, and I find the literature around this really interesting, even though I am by no means an expert in sort of the sociological research around this. But the research pretty consistently shows that interaction with computers causes more divulgence of information. You can see this in domestic abuse, divulging, sort of high-risk behaviors. People will do it more readily to a computer because they sense that it's more anonymous. So that's not really the trust and rapport relationship, but looking at video conferencing, I've seen a couple of papers where they are looking at in-person versus computer-mediated interviewing. And what they showed is that if patients are in private settings, they're not in the clinic where it's sort of this, situation they might not be familiar with. There's anxiety. If they're in their home, and especially if they can see themselves on the screen, there's sort of this self-awareness. There's actually significant differences in trust, rapport, and what is divulged. So I don't think it's necessarily the case that being separate will impair on average the relationship. I don't think that's probably a fair assumption. Will it change the relationship? I mean, it must. It probably will. But I don't know that that's predictable. And there's been some interesting findings about that.
And I don't think we should look at this as an either or. Let's not forget, with all this technology, there is still an absolute positive to the human touch. I just got off service in July, and I couldn't shake hands with anybody when I walked into the room. That was a big deal for me. I always introduce myself and shake hands with the patient. And now I found myself bowing because I can't shake hands during this pandemic. So even though we have all these new technologies, this is not like the technology is totally going to replace in-person visits, nor should it, because I think it's important to have that personal touch as well.
No, but you bring up something that's very significant in the fact that it may be more comfortable to use technology where you are distanced from someone rather than that frustration of being close and not being able to touch, because that does change. That changes the dynamic terribly when you go in the doctor's office and you're masked and they're masked and they can't touch, and it's a very different experience. So we want to, again, we don't want to compare apples and oranges, but I'd also like to just share my own personal response, because I have remained in the dark ages technologically for a long, long, long time. And I consider myself now in about the 20th century, but not the 21st century yet in terms of my response to technology. But I have to say that the experience of using Zoom as much as I have over the past few months has really opened me up and to be much more receptive to responding to people through this mechanism, and understanding that it will never replace the touching. But for me at this point, I find it almost more comfortable than being with someone I can't touch.
But what do you think if you have every 3 months one touch, or if you have in the meantime accessibility and short contacts in addition to physical meetings?
Right.
Because I know that a lot of people get non-adherent, they're just adherent after doctor visits and they do it for 1 week, and now over months they get non-adherent. And maybe some kind of interaction would help, right?
I actually think it's essential, and we need to prioritize it. I think, as Dr. Ramsdale pointed out, there's issues here where there's comfort with a remote visit, but there's also critical points of the human touch and relationship that's been eroded by physical visits because of the data clerk functions and how it interferes with the relationship and the bonding and the trust and the presence. And so that we need the gift of time, that is using technology to make synthetic notes. So there's a total attention, total presence. And those visits that are physical together are the way to restore the trust in medicine, because that is the essence of medicine. And sure, you can get away with the convenience feature and without parking and all these other things if you have a televisit. But for serious matters, like a new diagnosis of an important thing or a very critical matters about discussing a treatment with toxicity, all sorts of things, you need to be there. You need to be with the patient, because there's so many things that you can't pick up remotely. So I don't think we don't want the patient clinician relationship to suffer any more than it has over the last 4 decades, where it's been steady erosion. And we don't want to let telemedicine give way to this, what used to be an intimate, precious relationship that was the epitome of empathy and communication. And that's not the case these days for the most part.
Well, just on that, one approach that we've seen in the oncology setting, especially as patients are often on investigational agents with potentially unknown toxicities, or if they're being treated, if they're unable to travel to their clinical trial site because of COVID, that they, could be able to go to their local physician, their home physician, in other words, after first speaking to their clinical trialist about whatever symptoms they have, let's say immune-related skin toxicity, and describing that to their clinical trial physician, and then that physician collaborating with their at-home physician and going to visit their physician in their local, area, and then basically co-managing the patient. So that's been a strategy that we've seen utilized that I think could be potentially successful. However, does have some logistical ramifications, like coverage of basically 2 visits and the 1572 PI form, which is
Okay, so unfortunately we have to close this session. We are already over time, but I would like to take one sentence. That's what you said, that in the last weeks and months you said you enjoyed or you use this technology much more than before and that you admire it. And if this is the one message we can take out of this COVID, I would say we are on the right way, and hopefully this gives us a push forward by trying it out, seeing the value, and then not give up on the value we received after COVID. So thank you all for these great presentations, and we are going now to have a break, I guess, and Jennifer will definitively give us then more guidance on this one. Thank you and have a nice day. Bye.